allergy, and then we'll do migraine headaches and fibromyalgia, and that's everything in the notes. So, having introduced it as such, this was an interesting, I don't know to what extent you're aware of this, or maybe I'm the only one who sees it this way, but I think around 1965 there was a big change in the medical paradigm where medicine had previously been based on physiology, and then around, in my opinion, 1965 was kind of the magic number. It went from being based on physiology to being based on pharmacology. It seems like it was around that time that there was some shift in the way doctors were trained and the way they practiced. So sometimes I try to look at articles from around that era, and you'll notice that there's a clear distinction, in my opinion, between the language of articles written pre-1965 versus post-1965. Pre-1965 is considered old Medline, and it's harder to get those articles. But again, I think that there was a shift around that time where doctors went from actually thinking to just prescribing. So here's an interesting article, and you would never see anything really written like this these days. Allergic disease is a manifestation of a fundamental distortion of the mechanism through which the individual adapts itself on a cellular level to a hostile environment. These days, I don't think doctors really think of, medically trained doctors don't really think of, allergy in terms of a dynamic process. They just label it. Like, you've got asthma, you've got allergic rhinitis, you've got eczema, and you're going to have this forever, and it's a disease, and it's idiopathic, it's multifactorial, there's a genetic component, there are undefined environmental components. You're screwed, right? That's the allergy consult. You're screwed, you got to take these drugs. So we're going to talk about allergic rhinitis, asthma, and eczema. And you'll see, as we did yesterday, we'll see how we apply this protocol and how it makes sense here. So again, when we look at inflammatory imbalances and anything, but our focus this weekend is inflammatory imbalances, we're going to see how these connect with gastrointestinal status, hormones and neurotransmitters, detoxification defects, oxidative stress and energy production, obviously centers largely around mitochondrial function. So, these are pictures of common drug deficiency disorders. And that's the quote that I gave you just a few minutes ago. And again, the way that I look at this is just to try to address the underlying cause. So the ultimate question, of course, is why. And so, that's just the way that I've looked at things, and I try to understand why things happen the way that they do. Why did this patient never have an allergic disease, and then they went through a stressful period in their life, and now they're allergic to everything, right? So we can't say it's a genetic disease or a genetic problem, and we can't really, I think it's irresponsible to always say, well, there are undefined environmental factors. Why don't we step up and actually define them? So, and I'll give you some cases as we go through this. At the very least, I can give you my own case, because I was a kid growing up in Houston, Texas. I grew up with a lot of allergies. But later, during a period of my life at the end of chiropractic college, I started becoming allergic to everything. Skin rashes, gastrointestinal problems, and all this stuff, just kind of quote-unquote out of nowhere. And maybe I have my own case in here. We'll go through it and see what we come up with. So this is the way that allergy is commonly viewed. There's an antigen exposure. Obviously, there has to be some type of antigen absorption. There's this hyperactive immune response, of course, contributed to by the previously mentioned genetic factors and undefined environmental factors. And then this patient has some type of allergy or allergic rheumatism, if they have joint pain and or autoimmunity. And for a lot of doctors, I think they kind of think, antigen exposure, immune response equals allergy or autoimmunity, but there's a lot that goes on in addition to that. So it's not really appropriate to just think in that simple linear, 3 or 4 step pathway. We have to appreciate what's kind of going on in the background. And I think these are some of the things that are going on in the background. For example, if we just limit this conversation to food allergy, for example, it's not simply that a patient eats a food, they absorb the antigens, and they have a response, and nothing else is happening. A lot of other things are happening. They've got increased intestinal permeability, and so then the question becomes, well, why do they have that? Remember, we talked yesterday about 6 different causes of leaky gut, 4 of which you can exclude by history, so then that only leaves 2 more. It's either allergy causing leaky gut then causing more antigen absorption. So that can be its own vicious cycle. But what I see and what I treat a lot of times in patients is that they have GI dysbiosis. They've got an imbalance of microbes. So they're having a gastrointestinal inflammatory response, and that's what's allowing the increased absorption of antigens, and then they're developing food allergies. And then once we clear out the dysbiosis, I don't do anything about their allergies at all. I just clear out the dysbiosis in their gut and their allergies go away. So I think that, there's certainly a role there for thinking outside of the IgE and histamine box. Dietary molecular mimicry, that's more relevant to our next conversation on autoimmune diseases. Bystander activation, impaired digestion. So a lot, especially 10, 15 years ago, a lot of us were very interested in the idea of supplementing people, for example, with betaine hydrochloride and pancreatic enzymes to improve digestion. I still think there's a role for that. And there are certain patient populations where you'd want to be particularly attentive to that. These would be patients, for example, with vitiligo. If you work with a patient who's got vitiligo, it's obviously an autoimmune disease. And a lot of those patients will have what's called histamine fast hypochlorhydria or histamine fast achlorhydria, which means, remember, since vitiligo is an autoimmune disease and since there's often overlap with different autoimmune diseases, the overlap that you see very commonly with vitiligo is they have pernicious anemia and autoimmune atrophic gastritis. So the other place where you see that, and perhaps don't recognize it, a lot of people don't, but it's in the literature very strongly, in Harrison's textbook of internal medicine, for example. When you're working with patients who have autoimmune thyroiditis, Hashimoto's disease, I'm sure you've got patients who have that. About 30% of them will also have anti-parotid antibodies. So between patients with vitiligo and Hashimoto's thyroiditis, and a lot of times people have both, they often have histamine fast hypochlorhydria. So those would be patients who you might want to supplement with betaine hydrochloride and or pancreatic enzymes. So then what would be your patient base for jumping the gun on pancreatic enzymes? Usually patients with acne rosacea is probably the best example. So patients with acne rosacea are pretty classically known to have pancreatic insufficiency at a higher prevalence in the general population, and if you supplement them with pancreatic enzymes, you can get some symptomatic relief in their skin lesions. So who else has hypochlorhydria and impaired digestion, which is what I'm focusing on right now? A lot of people, right, because they take drugs. Omeprazole, Prilosec, Tagamet, cimetidine. So what happens to a patient who takes, for example, cimetidine or omeprazole? Right, so cimetidine is a histamine 2 receptor blocker. It's an antacid drug, right? And you can remember it's a histamine blocker because it ends with INE. So cimetidine, antihistamine. So what's the consequence of that drug? Short term, if you're a drug company, you only want to look short term. So these studies are going to be like 6 weeks to 6 months at the max. They never find nutritional deficiencies, right? But when you look at the longer term studies, they find nutritional deficiencies. Of course, the drug's already been approved by then. So what happens when we turn off the stomach? Well, the stomach's not functioning and carrying out its normal roles. So what would that be? Protein digestion and sterilization of, upper gastrointestinal tract. So the patients are predisposed to getting nutritional deficiencies, especially zinc and B12, and bacterial overgrowth of the small bowel, which I already mentioned. What cimetidine does, and omeprazole does the same thing, is they both inhibit the cytochrome P450 pathway as well. So anytime you're working with those patients, they're predisposed to having nutritional deficiencies, bacterial overgrowth of the small bowel, and impaired detoxification. Cimetidine is probably the worst. Cimetidine basically turns off liver detoxification pathways. Omeprazole does the same thing, but slightly lesser. So, people are starting their day in a disastrous way. Nutritional deficiencies, bacterial overgrowth, and turning off their liver detoxification pathways with the over-the-counter drug. So, what else happens here? I think I'll just leave some of the other boxes on that slide to kind of speak for themselves if you want to read it later, but increased mucosal permeability, I think, is a major factor. We talked yesterday about vitamin D's role there, according to the animal studies that have been done. Vitamin D is important for maintaining the integrity of the gastrointestinal mucosal lining. So if people are vitamin D deficient, we might expect that they would have leaky gut and therefore absorb more antigens. I think that's all I'll say about that slide. But the major point of this slide is just to say there's more going on than a simple response to a simple antigen. And I'll go back one more time. If we can address some of these contributing factors like leaky gut, then I think we can help these allergic patients get better. So what's the recipe for leaky gut? So let's say you've got a patient who comes in and you think, wow, this patient's got leaky gut. What are you going to do about it? At least what I do about it is, number one, try to find out what the offending agent is. So gastrointestinal permeability is very tightly regulated. And if a patient has leaky gut, it represents a major physiologic failure. Like, this is not something that just the body's going to let happen if it can prevent it. So again, we have to go through our differential diagnosis. I gave you that yesterday. But the two things that are most common are allergies and dysbiosis. And maybe we need to add vitamin D deficiency in there as well. I don't think human studies have assessed that, but it would certainly be easy for them to do so. So first of all, let's try to find out what the offending agent is, whether it's a dietary antigen, microbial overgrowth, or perhaps vitamin D deficiency, which can easily be treated and corrected. Other than that, there are, of course, some supplements you can use to help tighten up that leaky gut, right? Regardless of identifying the cause or not, there are certain nutrients you can use. Glutamine is one of them. Glutamine is a tasteless white powder. People can mix it in water or juice. They can eat it very easily. Typical dose on that would be somewhere between 6 to 9 grams 3 times a day between meals. Easy, slam dunk, and it works. Zinc alone has been shown to be helpful as well. It's relatively high dose. There was a study published in patients who had Crohn's disease, and I think they were getting around 100 milligrams per day of zinc. And what they showed in this study is that by giving them high dose zinc, they were able to tighten up those leaky junctions between the cells and therefore correct the leaky gut phenomenon. So glutamine, zinc, vitamin A would be another one. We talked about dosing. You have a question?
You keep them on 100 milligrams of zinc?
Maybe just 1 or 2 months. You know, I think that would be fine. I mean, that's a pretty high dose. We have to balance it with copper, but if they're on a multivitamin, most multivitamins have 1 to 2 milligrams of copper anyway. I think we're going to be okay. So, and we can, like, you know, any path that we begin a conversation on, we can all obviously take that path for a while. So what would happen if so what's the risk to using zinc? Beyond the fact that it just causes nausea if people take it on an empty stomach, copper deficiency is the big risk that we think about, because high-dose zinc supplementation basically blocks copper absorption. So then people become copper deficient, and how do you identify that? One of the earliest signs of copper deficiency is what's called neutropenia, so impaired production of neutrophils. So you just check their CBC. If you see their neutrophils start to drop, that's one of the earlier signs for copper deficiency. Sometimes their cholesterol and triglycerides will get elevated as well. So those are things you might monitor. But again, if you've got them on a good multi that's got 1 to 2 milligrams of copper, it'd probably be all right. And especially if you limit the duration of high-dose treatment to 1 to 2 months. And you don't have to go 50 to 100. You could go 25, 50, something like that. You have to, you know, just ballpark it. Dose to response, as we say. But it also depends on the patient. You know, if you think they're zinc deficient, then you might hit them with a little more. If you don't, you know, if they've got like white spots in their fingernails and things like that. So let's see. So we just took a tangent onto copper. Let's come back to zinc and leaky gut. So glutamine, you know, I usually use about 18 grams a day, maybe a little more, 27 grams a day, somewhere between 18 and 27. Empty stomach, pretty non-toxic, as long as they don't have, you know, hepatic failure or something. So glutamine, I mentioned zinc, vitamin A, we talked about dosing that yesterday. If I think a patient's deficient, I usually hit them for the first week with 100 to 300,000 international units per day, and then we taper down to either 10,000 or 25,000 per day. I think that's very safe. I'm not concerned about toxicity, but just to make sure that you understand the way I think it should be done, you always, anytime you give high-dose vitamin A, you always want to give those instructions in writing and limit the duration of treatment. Just be very clear with your patient, because you don't want to say to them, "Oh, I want you to take 300,000 units," and they come back 6 months later still taking 300,000 units, right? Because they're going to come in a little toxic. So what are the signs of vitamin A toxicity? headache, bone pain, dry skin, chapped lips, things like that. So what else can we use? Bovine colostrum has been shown to help tighten up leaky gut. For example, in patients who take nonsteroidal anti-inflammatory drugs. There have been studies using bovine colostrum to help reduce the leaky gut caused by those drugs. That's all that comes to mind right now. Anybody want to add anything to the leaky gut formula?
Slippery elm.
What's that?
Slippery elm.
Okay, so slippery elm, some botanicals. That's one of kind of a soothing botanical medicine used in naturopathic medicine quite a bit. Maybe aloe vera too, something like that. So those are some things I think about. I'll leave it at that. The only other thing I'd say as far as impaired digestion goes is you also want to look at patients' hormonal status. Patients who are low in hormones kind of across the board, whether it's cortisol, testosterone, or thyroid hormone in particular, will have impaired digestion. So sometimes if you're looking at a patient with impaired digestion, you might just want to see what's going on with their hormones. There's a very interesting case report published. It was around 1963 or something like that. It was a long time ago. But this was a patient who had complete achlorhydria. It was a male patient. This was a really interesting case report. I don't even know why they published it. But it was a patient who had achlorhydria, and the patient had what's called panhypopituitarism, which means his pituitary gland wasn't working. Maybe it had hemochromatosis or head injury or something like that. Anyway, all of his hormones were low. They gave him thyroid hormone, cortisol, and testosterone, and by giving him hormone replacement, in the true sense of the phrase, he was able to actually start making stomach acid again. So anyway, interesting case. Allergic rhinitis, conjunctivitis, asthma, I think these are kind of the prototypical allergic conditions. Standard medical evaluation, so how would you evaluate allergic rhinitis? You just take their history, you look up their nose, if it's boggy and edematous, you got allergic rhinitis. Assuming it's not a viral infection. Asthma, we can do spirometry, you can listen for wheezes and things like that, but it's a relatively straightforward diagnosis. If you're going to be real official about it, what we have to do is document reversible airway obstruction, right? So they get like I think it's called, is it methacholine or acetylcholine challenge or something like that, to be able to assess them for bronchoconstriction. Then if it's reversible, then we call that reactive airway disease or asthma. Eczema, atopic dermatitis, I think that's a pretty straightforward diagnosis as well. A lot of times doctors in general, and perhaps medical doctors in particular, seem to name almost any rash eczema. I've even seen some patients come in with psoriasis and they're diagnosed with eczema. It's like, are you kidding me? Like, that's like comparing a cat with a tiger. They're totally different. The distribution's different, the demarcation's different. But anyway, you see a lot of little kids with eczema. Sometimes I think it's probably more like seborrheic dermatitis, but they just get stamped with eczema and they get put on steroid creams. So what else do we do? Physical exam, blood oxygen. You can do what's called pulse oximetry, where you just put a little clip on the patient's finger and you can determine their oxygen saturation. That's pretty important. Spirometry, allergy tests. They still, a lot of allergists still do skin prick testing for IgE-mediated immediate allergies. And I have an interesting story about that. So in my fourth year of medical school, I was going through pediatrics, and I spent a day with a pediatric allergist. And for whatever reason, we were about to do skin prick testing on some kid in order to justify, prescribing drugs. And he's getting all the samples together and all this, and he said, here's the histamine challenge, right, or the histamine standard. So he injects the kids with histamine, and then based on their response to that, he can see how they respond to other things, right? So that's kind of the control. Well, he pulls out the histamine needle, and he's putting all the drops in their little pipette things or whatever, and he sticks me in the arm with this histamine needle. Kind of an uncontrolled and unapproved experiment on me. But he did it in kind of a joking way, so it's not like I got upset about it. But anyway, he sticks me in the arm with this histamine needle, and he says, well, here's histamine, boom. And he says, let's see how you react. Great. Well, the interesting thing about it is I had no response at all. And he says, I've never seen anybody not respond to histamine. And I said, yeah, well, I take some nutritional supplements. He said, that can't be it. Of course it can't be it, right? It's the only obvious answer. So standard medical treatment, and I'll tell you, I mean, so what do I take? You know, obviously vitamin C, quercetin, a lot of flavonoids, a lot of green tea, CoQ10, you know, things that his patients don't take, but that's why they're all sick. Bronchodilators, beta agonists, so you'll see a lot of patients with asthma, of course, they're always carrying albuterol inhaler. And there's a stepwise progression, or at least there had been. The way asthma had been managed for many years was like a 4-step plan. Rescue inhaler, usually albuterol, and then, let's see, another inhaler like leukotriene agonist with a steroid, and then eventually oral steroids and things like that. So there's kind of a stepwise progression, which obviously I'm not remembering in detail right now. But these are the typical drugs that are used. Beta agonists, albuterol is a prototype, steroids, prednisone, either inhaled steroids or oral steroids for really severe asthma. Leukotriene blockers, such as Singulair, for example, because asthma is very much a leukotriene-mediated disease. So then we have to talk about how we can influence that nutritionally. Anticholinergics to a large extent still. But basically the goal is to drug or suppress the manifestations of immune dysfunction and completely ignore the fact that, you know, some of these components are actually treatable. Standard medical management of allergy fails to address the underlying cause of immune dysfunction, but that's what we would expect. Leaving patients dependent on medications, high costs and serious adverse effects. Allergic rhinitis and conjunctivitis, generally considered to be local IgE-mediated response to airborne allergens. Pretty easy diagnosis, clinical assessment, rhinitis, runny nose, mucosal edema, watery eyes, eosinophils, if you're going to do like some type of microscopic exam. You can test total IgE in your patients, and it's impressively cheap. So if you're working with a patient who's got a lot of what you think are immediate onset allergies, or they've got eczema, about 40% of those patients, I think, have what's called hyper IgE syndrome, which means they're just responding to everything. I've got one patient right now with really bad eczema, and she had a really high total IgE level, and I'm trying to get that down. I think I talk about that in here. Go ahead.
Will the antihistamines or steroids affect those IgE levels if you're testing them?
Steroids, yes. So his question was, will those drugs interfere with the IgE levels if you're going to test it? The antihistamines I don't think will, but the steroids certainly will. So yeah, you'll get a false negative basically. So this is basically what patients get, and I don't know how many of you have had allergies. Like I said, I grew up with allergies, so I used to get allergy shots, all this medications and things like that. So antihistamine, antihistamine drugs, steroid drugs, prednisone, topical steroids, anti-leukotriene drugs. That's pretty much the standard. Asthma, reversible airway obstruction caused by inflammatory response. Again, one of the major mediators is leukotriene B4. So we'll talk about that later. Evaluation, wheezing, reversible obstruction, spirometry. A lot of that you can do in your office. Not too many labs are performed for this. And we already went through the drugs. Eczema, atopic dermatitis, one of my favorite conditions. Favorite as in it's easy and it's kind of a slam dunk. I wouldn't care to treat it because I like autoimmune diseases more. IgE-mediated redness, blisters, itching, clinical evaluations sufficient for diagnosis. Antihistamine drugs, again, steroid creams. Yeah, so what can we do about that other than just drug these people? Sorry, let me go back to that. So let's go through the protocol and see how it applies to allergies. So we've already talked about food-induced inflammation. One of the things that I think we want to keep in our minds when we think about inflammation and therefore when we think about allergy is, again, what I referenced yesterday called total inflammatory load. So, you know, if a patient comes in with allergy, they've got more going on than simply allergy, right? The allergic disease is not causing itself per se. So then the question becomes, how can we deconstruct the phenomenon of what we're seeing? And let's try to deconstruct allergy by reducing total inflammatory load and restoring immune balance, right? Restoring immune balance. Oxidative stress, immune suppression, phytonutrient deficiency, those are all consequences of eating junk food diets, which a lot of people do. In fact, and I think I have this in the slides, when people transition toward a Mediterranean diet or a paleo diet, it actually reduces the incidence of allergy. So we can actually use the paleo diet that we talked about before for its anti-inflammatory and therefore anti-allergy effects. Oxidative stress is important, number 2 here. So I just want to talk about that while I'm thinking about it. When you're working with patients who have asthma, one of the nutrients you can use, which I think is commonly overlooked, is selenium. Again, for adults, 600 to 800 micrograms per day I think is reasonable. But selenium is obviously a nutrient that has many roles. One of those roles is it blocks NF-kappa B, which is activated in patients who have any type of inflammation, but allergy in particular. So again, the benefits of selenium: first of all, it's safe. Second of all, it blocks NF-kappa B, which therefore downregulates the expression of these pro-inflammatory mediators. But in particular, since it functions as a cofactor for glutathione peroxidase, it helps to quench free radicals, right? And part of at least this is the way that I think about it. I think this is correct based on what I read. It's in my chiropractic and naturopathic mastery book. If anybody has that, we can look it up. But what I recall reading is that the production of leukotrienes, which are one of the main mediators of allergic or asthmatic inflammation, the production of leukotrienes actually requires the presence of free radicals. So it's as if, this is my model. Let's say this is arachidonic acid, and we're going to try to convert arachidonic acid into a leukotriene. That conversion process actually requires the addition of a free radical. So if the patient is in a very highly saturated antioxidant state through, for example, the use of nutrients and selenium in this conversation, then there are going to be fewer free radicals around for the production of this leukotriene over here. Does that make sense? So that's how antioxidants have an anti-asthma effect, is they quench the free radical that's necessary for the formation of the leukotriene from arachidonic acid. So I think there have been 4 or 5 studies using selenium in kids who have asthma, and it's reviewed in my book, but I think 3 out of 4 or 3 out of 5 studies showed a positive benefit. And some of those studies only use 100 micrograms, which is too little. But I think that explains how we can use antioxidants for an anti-asthma effect. Sugar and insulin excess, we talked about that yesterday. GI dysbiosis, I think that's critical because, again, we're not simply treating their allergy. We're trying to restore immune balance, and we're trying to reduce their total inflammatory load. So then the question becomes, well, where are they getting inflammation from? And junk food diets are part of it. Food allergies are part of it. Dysbiosis is part of it as well. And I think I've got some cases in here. We'll get through them. Deficiencies of vitamins, minerals, ALA, GLA, EPA, and DHA, that certainly contributes to asthma. So the combination of, well, GLA is one of your best nutrients for blocking leukotriene formation. So anytime you're working with a patient with asthma, you definitely want to think about GLA, and there's a botanical medicine called Boswellia that you also want to think of because it functions primarily through blocking the enzyme 5-lipoxygenase, which is what converts arachidonic acid into leukotrienes. So, if you had to treat somebody right out of the gate on day 1, which of course you would, and I certainly would, if they've got asthma, they're going home with combination fatty acids and they're going home with Boswellia, because the combination of GLA with Boswellia will help target that lipoxygenase enzyme and produce some anti-asthmatic effects.